Okay, so let's now talk about bones, nerves, and inflammation. So we'll talk about musculoskeletal trauma to the bones here around the elbow. Who's next?
Um,
Okay, we have a 20-year-old, both forearms are in pain for 4 months. Uh, both ulnar tenderness. Okay. So first we have a bone scan. At the top we see uptake within the ulna, I think, yeah. Radiographs, some periosteal or cortical bone thickening. MR, we see, yeah, some thickening of that. Looks like the periosteum. Um, yeah, interesting. Not a lot of edema around it. Um, uh, could it be, could be like a traction change from repetitive use from maybe a muscle attachment?
Right. So this is actually the attachment of several of the flexor muscles along the diaphysis.
Okay, so here at the capitellum, looks like there's an impaction fracture
Okay.
again.
See this here, we got sagittalus.
Um, yeah, edema in the capitellum. I think, yeah, we see this normal defect posteriorly, but I don't see an impaction or, uh,
So, but this is clearly articular surface here,
yeah.
and it's not. And here we
Hello? Yeah.
John, you're back.
Yeah, I needed a little help.
Good. I'm glad you got it. So, John, here's a case where we have an osteochondral fragment here. We had two little bodies in that location. They debrided this. So, do you want to tell us if you let me go back and show you the previous one. Here we can see that osteochondral fragment in situ here, but it's unstable with fluid going deep to it and then a lot of subchondral cysts. So I was just talking a little bit about treatment options from this. And back in 2007, they did a debridement alone on this case. But I was saying that now people would have a tendency more to do osteochondral grafts. Do you want to comment on that?
Um, I think osteochondral grafts are doable in this area. Um, they would be allografts, I think,
Okay. Yeah.
and you just have to pick the right size and then put screws in it
Okay. Good.
to fix it. I don't know what other option you have.
Okay.
It's way too young to put in a prosthetic type of device.
Right.
Okay. So looking at the elbow again and looking at the trochlea, it looks like there's a chronic appearing injury. And yeah.
Right. Now this one did not have prior surgery.
Mhm.
John, how well do these people do with these large osteochondral injuries to the elbow? Are they still pretty functional or not?
Um, the literature doesn't really say too much. Not in Campbell's, it doesn't.
Okay.
Um, that's one of the treatments, and that's about as far as they go.
Okay.
So I really cannot give you any numbers.
Okay.
I'm
Thank you.
sorry.
That's fine. Good.
Okay, so right, there's been a capitellar fracture, as we see on CT. Looks like an oblique defect, also involving the trochlea. Um, okay, so maybe because it involves both sides, maybe it's a dislocation. Is that what's?
Well, it's a fracture. There is a classification system. Uh, I don't really want to go through this again. I think you should just describe it. Like everything, there are multiple classification system. If you're dealing with a surgeon who you work with a lot and he has his classification or she has her classification, then it's probably good to learn it and use it to help them out. But in general, I find it's better just to describe these because and there are often new classification systems that people may use that you're less familiar with. But it just shows that the more fragmented it is, the more difficult it is to handle.
One problem with the elbow, it like has a tendency to get stiff, so you cannot immobilize the elbow very long for adults. For kids, it's a little better. You can immobilize longer, but not for adults. Fortunately, kids heal faster, so a short immobilization is usually all that's necessary. But fixing this problem in the elbow is always difficult. It's not. It's. I think the hand surgeons should be doing these procedures, not just an ordinary orthopedic surgeon.
Okay, thank you.
All right, so looks like we have a fracture through the coronoid process.
Right, and these are fairly common coronoid process. So it's important if you see trauma always to spend at least a second at the end to look at the coronoid process because they're kind of easy to miss sometimes. But as you can imagine, a fracture like this, and this is unstable bone, it can lead to an unstable elbow. So it's important just to make sure you don't miss these.
The main thing in that kind of an injury is how much of the coronoid process is involved.
Okay.
A chip fracture is you can remove it if it's causing pain, and that there's not a big deal. But if it's a big one, then you have to repair it.
Okay.
All right. So it looks like we have a pediatric elbow. It looks like there's a big jointed fusion. I don't see a discrete fracture, but certainly be concerned for one.
You do see a fracture, or you don't?
I did not, but
Well, the arrow is right there.
yeah.
So-
It's a bone missing from the joint. What do you think that bone is?
So what do you want?
I'd like an MR or a CT.
How about the radial head is missing?
Yeah, it looks like it's the radial head is displaced and rotated. Yep. Wow.
So
See on X-ray, you don't see it, except for a small portion of it.
Mhm.
No, if you did a couple of different turns of the forearm when you X-ray, then you probably catch it. But what you saw, that's kind of a trick X-ray.
Okay, so here, looking at the radial head, on the PD FATSAT image on the right, looks there's edema in the radial head and neck. Is it a contusion? I don't know if there's a
So there's a
fracture.
lot of lymphedema there and big effusion here. Yeah. So it's just a radial head fracture. This is pretty straightforward, not a lot of deformity in this particular one. This was one you might be able to treat with conservative treatment.
All right, this one not so much treatable with conservative treatment. Radial head and neck fracture, and there's some angulation anteriorly.
So, John, do you want to teach us about radial head fractures?
Well, there are those that you can fix, and those that you cannot. And the ones that you cannot, you just remove, but you leave as much of that ligament as possible. And ordinarily, the patients do fairly well. They don't usually go into radial, into valgus. They usually stay pretty well. Their chip fractures, they now have very tiny little screws that you can still fix those. But the more fragments you have, the worse things are. So if you have a lot of fragments, the best thing is to do is probably just remove them and leave a space there. For kids. Now, when you get to the age of 40, 50, there are prosthetic replacements, but don't use silicone. Silicone will not work. Silicone just falls apart within a year.
Okay, thank you.
It fragments into little pieces.
All right, so this is a 51-year-old female status post fracture, and it looks like she's had a prosthesis, a lot of heterotopic ossification.
No. Okay. Elior, another patient.
Okay, status post reconstruction. So it looks like they had a prosthesis in the radial head and neck. Um, Prosthetic looks fractured, the radial head part, and there's just general destruction of the joint space with the fusion and synovial thickening.
So this was what John was just referring to.
Yeah, that's not a very good prosthesis, is it? It fell apart.
So, so this is what John was referring to, is that these, if you use a lot of the early prostheses would fall apart, and some of them like this could also create foreign body reactions, all this synovitis, and a lot of erosive changes within the bone are all due to the inflammatory reaction from the prosthesis. But then, they don't use these anymore.
Synovectomies can be done here, and of course you remove the fragments of the foreign body, but you got to be very careful about synovectomy in elbow. There are a lot of nerves that can be injured inadvertently because they're very close to the joint.
Okay, thank you.
If you push on a capsule, don't push it too far. So stay inside the capsule.
Okay. And this just shows a fracture dislocation, showing the CT scan. We need the rest of the study to really fully describe the different fragments and locations and so forth. Okay, here's a kid.
All right. So left image, I see some edema in the capitellum. The the radiocapitellar articulation is not congruent still. So there's still some lateral subluxation there.
You would probably want to get
Is
an
that
image distally of this, so there's something not right, and probably distally.
lateral epicondyle?
So there's a bone fragment here.
Yeah.
Yeah, so that was a lateral epicondylar avulsion. Okay. Yeah, I think John likes to get CTs in these also to better
Yeah,
visualize the
I certainly would.
Yeah. Okay.
At this point in time, there's not much you can do with this patient, actually. But if you see what you have to do, maybe that would help.
All right. So looking along the medial side, there's a lot of edema and there's this hypointense structure, curvilinear. Would be concerned for an avulsion fracture. Uh, yeah, similar amount of large edema there.
Yeah. Good. Uh, why don't we stop here? Because we're going to go into the olecranon next, and that's a bigger topic. So we'll stop here and we'll start up tomorrow. Okay.
Well, have a good evening, everybody.
Thanks,
See you
John.
mañana. Take care, everybody.
Thanks, John.
Thank you.